Hi students, today we will discuss about all important points about meningoencephalitis. So these are the types of meningoencephalitis: bacterial, viral, fungal, parasitic, but most common are bacterial and viral. Symptoms of all meningoencephalitis, they are same: high grade fever, neck pain, sleepiness, vomiting, joint pain, headache, fits, photophobia. So these are the symptoms which are common to meningitis as well as encephalitis. Then after that are the signs of meningoencephalitis. This is neck rigidity, and then this is Kernick sign, in which you flex hip of the patient and try to extend leg. So patient will feel pain in his hamstring muscles if he is having meningitis. Brudzinski sign is if you try to flex neck of the patient, both knee joints flex. This is called Brudzinski sign. So this is also very common in meningitis. But absence of these signs do not mean that patient cannot have meningitis. So bacterial or pyogenic meningitis, most common organisms are pneumococcus, meningococcus, and Haemophilus influenza. While in infants younger than 2 months, E. coli and group B streptococcus, they are also very common. In young age group and in aged people greater than 55 years of age, listeria is also very common. So we have to give cover of listeria meningitis. The investigations are lumbar puncture. Normal lumbar puncture is given, then bacterial. In bacterial meningitis, whether it is acute pyogenic or tuberculous meningitis, glucose is decreased, proteins are raised. In acute pyogenic meningitis, cells are increased, but they are neutrals, while in tuberculous meningitis, there are lymphocytosis. So this is MRI scan of meningitis, in which you can see meningeal enhancement as evident by white lines. This is another MRI which is showing complication of tuberculous meningitis, tuberculomas, which are ring-like lesions, and it's a complication of tuberculous meningitis. Then after that, this is encephalitis. In our setup, herpes simplex encephalitis is very common, that affects temporal lobe. So there is temporal lobe enhancement. As far as treatment of acute bacterial meningitis is concerned, we give third generation cephalosporins, or we can give meronam, or we can give chloramphenicol. But today, these days, we do not give chloramphenicol. And in very young patients and in very old patients, we cover listeria with ampicillin or amoxicillin 2 gram 4 hour. So after the treatment of acute bacterial meningitis, we will discuss something about viral encephalitis. Viral encephalitis most commonly here is because of herpes simplex. Features are same as that of meningitis, but management is with intravenous acyclovir. One thing to remember is that lumbar puncture is not diagnostic in case of viral encephalitis. Diagnostic is PCR of CSF, which shows herpes simplex, or MRI can show temporal lobe enhancement. Whereas lumbar puncture is inconclusive, it only shows that glucose is normal, and this is in contrast to bacterial meningitis. Otherwise, proteins can be mildly raised and lymphocytosis can be there. In case of pyogenic meningitis, we can have sensory neural deafness or meningococcemia, which is a severe condition in which there is TIC, platelet count is low, so there is bleeding inside adrenal glands, so patient can present with adrenal insufficiency, which is called Waterhouse-Friderichsen syndrome. In tuberculous meningitis, there can be many complications if left untreated, like hydrocephalus, seizures, cranial nerve palsies, and then hemiplegia, paraplegia. So treatment of tuberculous meningitis is 12-month ATT with steroids in order to prevent adhesion formation. Close contact of patient of pyogenic meningitis can be given single dose of ciprofloxacin or rifampicin. Thank you.